I'm Kim Cantor, and Carol Chase and I are thrilled to be co-moderating this session this morning. We appreciate all of your attendance. Like the other workshops you may have attended yesterday, after each presentation, we'll have a brief Q&A with the presenter. Please use the Q&A tab to submit questions. Carol and I will be keeping a close eye on things, and we'll look forward to talking with you in between the talks.
Hello, everyone. My name is Rana Tabi. I'm a PhD student at University of East Anglia. Today, I'm here to present my poster, or my abstract, it's about exploring the nature of perceived treatment burden in adults with cystic fibrosis. So this work is part of my PhD. So a quick disclosure, there is no relationship to disclosure related to this presentation from the presenter side. So to start off, people with cystic fibrosis have a lot of treatments and medication to take daily. And due to that, treatment burden could create an issue for them as they rise with this amount of treatments and maintenance. Therefore, it's important for us to seek ways to reduce treatment burden for this population. However, treatment burden is not yet fully understood as a concept. According to James Lind Alliance top CF question list, treatment burden ranked top research question for people with cystic fibrosis, caregivers, and clinicians. So the purpose of this study is to evaluate the treatment burden perceived by people with cystic fibrosis or adults with cystic fibrosis and explore the association between different treatment burden measures. So this is a cross-sectional observational survey study done in a single large UK adult CF center. The participant demographic and clinical data were collected from the survey and from the closest encounter data from the UK CF registry, in addition to their medical record from the CF center. So the survey contained, we sent an online survey to the participants, and the survey contained 3 treatment burden scales. First, we have the treatment burden subscale from the CF QR, which have 3 items. And then we have the treatment issue subscale from the CF QOL that also have 3 items. And then the generic multi-morbidity treatment burden questionnaire, the MTBQ, which has 13 items. As you can see, the table below shows the items for the CFQR and the CF QOL subscales. Those subscales majorly ask about how treatments has made their life difficult and how much time they spend daily to do their treatments and how the treatments have affected or interfered with their life enjoyment in life. While in the generic MTBQ, the items more focus on the logistic aspect of treatment burden, like the financial impact caused by the treatment expenses, in addition to the administrative aspect of treatment burden, like monitoring health at home, arranging appointments, collecting medications, and also lifestyle changes that could be caused by the disease, like dieting and exercising. So in order to assess the performance of the treatment burden instrument, we also gathered information related to their treatments from the survey and from the UK CF registry. The first one being the number of treatments they take daily and the number or the time they spend daily to complete their treatments. Also, we calculated the treatment complexity score, which is based on a scale developed by Sawicki, with some modification that we have made to the scale to add some treatments that were not included in the original. So this scale gives each treatment or medication specific score ranging from 1 to 3, according to the frequency of the treatment, how hard it is to keep taking the treatments, and the maintenance process for that treatment. So this is the table for the modified table that we had from Sawiki. The white cells here, or the boxes, are the from the original Sawiki study. And you have here the gray boxes is the one that we have added into Sawiki original scale. So in this study, we had a total of 103 respondents to the survey. We removed 2 participants from the final analysis because we didn't have their demographic and clinical data. The median age in this study was 34. Half of the sample were females, and the number, 28% or 29% of the participants in the study received an IV antibiotic course a year prior to the enrollment in the study. As for the lung function, the percent predicted FEV1 mean in the sample was 69. The sample had a median number of daily treatments of 14, a treatment complexity score mean of 24, and the median total treatment time was 80 minutes. So as you can see here in the graph, it shows the distributions of the treatment burden instruments across the sample. As you notice here, the CF-QoL has the widest distribution, ranging from 0 to 100 compared to the other 2 instruments. So how the 3 treatment burden instruments uses a 0 to 100 scale. 0 meaning high treatment burden, and 100 means low treatment burden. We wanted also in this study to assess the correlation between whether the treatment burden differs across different disease severities. So we divided the sample into 2 groups. The mild group, which based on the FEV1 more than 70%, and moderate to severe group that has an FEV1 less than 69%. And you can see here in the table how the difference in their score, or the scores in the treatment burden scales or instruments between the groups. We ran a Mann-Whitney test to see if there is a significant difference. As you can see here, there was no significant difference in treatment burden between, as measured by the 3 treatment burden instruments across the disease severity groups. So across the whole sample, we found that there is no association found between age, gender, BMI, and the number of IV antibiotic courses received a year prior to the enrollment, and treatment burden measured by any of the 3 instruments. Also, we found that more treatments, longer treatment time, and more complex treatments associated with high treatment burden as measured by the CF2R and the CF-QoL treatment burden subscales, but this was not observed with the MTBQ. Also, we wanted to check the correlation between the 3 treatment burden instruments, and we found that the 3 instruments were actually correlated with each other, and the strongest correlation was between the CF-QR and the CF-QoL subscales. So in the end, to conclude, in this cohort, according to the CF-QR and the CF-QoL subscales, it's indicated that treatment burden is considered a substantial issue. Both of these subscales are considered the most appropriate way to evaluate treatment burden in adults with cystic fibrosis. Both of them showed that more treatments, longer treatment time, and more complex treatments are associated with high treatment burden. On the other hand, the MTBQ showed a poor correlation compared to the other 2 subscales. This could indicate that it could be capturing some other concepts than that being captured by the other 2 subscales. And this is could be due to how it was developed in an older population with multimorbidity, but not in the CF population. So before I end my presentation, I would like to announce that this study was funded by the National Institute for Health Research. The study was set in Royal Brompton Hospital, UK, London, and the study was done with the collaboration of Royal Brompton Hospital and University of Central Lancashire. Also, special thanks to the co-author in the study that helped me do this work. Thank you very much for listening.
Good morning again, everyone. Thanks for participating with us. We have Rana Altalbi here with us from London, as she said, and we again encourage you to send in your questions through our Q&A tab and not the chat. To get us started, Rana, we do have a couple for you. From one of your colleagues here on the moderator session, did you look at a number of medications or medication categories for these groups?
Yeah, thank you very much. Thank you for having me. So yes, we did look into their type of medication they're taking, and we did categorize them. And the best way we did it is that we used, we looked to assess their treatments based on the number of the treatment they take. And then for those categories, we put them into a scale, a treatment complexity score that was developed by Sawiki, and we did some modification. And based on how this treatment is taken, the time this treatment takes, and the maintenance process, that's why we give them each like a complexity score, and this is how we categorize them. And yeah.
Great. All right, next question. So previously in some other studies, airway clearance and nebulized therapies have consistently been described in the literature as most burdensome. Did your study in particular look at these treatment types and see this pattern, or was there something different?
Well, we did include, we did of course have a participant who did take nebulized treatment, of course. The treatment burden looked into, the instruments looked into it as a whole, how all those treatments came together and affected treatment burden. So there wasn't a way for them to report whether those specific inhaler or nebulizers were specifically burdensome, but all of those treatments were together caused or resulted in for them to have a high treatment burden.
Okay, and a couple more from your audience. Thank you for sharing your program. Have you explored any interventions or response to patients who reported high burden?
Response, you mean like?
Interventions or responses to the patient?
No, there wasn't an intervention. It was, so the study was cross-sectional. It was just reported in their registry. So we did hand them a survey, and they completed the treatment complexity, or they completed the treatment burden scales. And we looked into their treatment, or we looked into their registry information a year from the time they completed the survey, and we did have all their, like, the numbers of treatment they take and what changes, also like what are they on by the time they did the survey, and we made sure to have specifically what treatment regimen they were doing by the time they completed the survey. So.
Great. And one more question. Did you explore which medications patients were most eager to stop taking due to the treatment burden? And were those medications with the highest TCS scores?
So it's a good question. For my study, we didn't do that. But I highly recommend you to go to, so I have my colleagues we work on the same data. Rory Cameron, he's doing a poster in the conference where he talked about what treatments the people, the CF patients were really eager to stop, and what they were trading off with quality of life. So it's a really very good study, and I recommend you to like look into it.
And one last question, do you have a poster associated with this work that you can refer people to?
Yes, there is. And my poster is in this conference. I don't recall the name, the number, sorry, the code. I think 295 or something like that. I'm not sure the number of the poster, but it's the same name as this presentation in the workshop. So I have it there. So you can go
Great.
there.
And I think we can look it up by your name too.
Yes.
Rana, thank you so much for a very, very interesting presentation. Maybe just one more question, since we're focusing on managing care and moving forward in the future, and we've heard so much about the impact of modulators. Do you have any thoughts about next steps for this work, or how we might be able to reduce treatment burden moving forward based on the work you've done and your group has done?
Well, this is a really good question. And I feel like treatment burden has been there, but through the years, I think for clinicians, they were only focusing on like respiratory aspects of the treatments, a dietitian and those kind of things. So the physician tend to like give treatments a lot and not think about, or maybe how the patients is affected by that. But like, especially with the new era of CFTR modulator, and how this is like changing the game here, and how it's like we can now look into reducing some of the treatment that patients are on. I feel having a treatment burden measures be there in the process of decision making for the future, like giving treatment regimen for people with cystic fibrosis. I feel it's important to incorporate this measures into this decision, and to reduce and think more of the patient's aspects on how these treatments affecting them. So,
Rana, your wonderful colleagues have rescued us. It's poster number 295, if anyone's interested in looking it up.
That's right.
Thanks, guys, for joining in. Love our audience.
Thank you very much.
Great. Well, thank you for that insight, and I think incorporating measures of treatment burden into clinical care is a really fantastic suggestion. If we don't have any other questions for Rana, I think we're ready to move to the next presentation.
Hi, I'm Megan Fleischman. I am the pharmacist in the Adult CF Center at Froedtert and the Medical College of Wisconsin. I'm presenting today to you on my project titled Patient Characteristics Based on Calculated Adherence to Cystic Fibrosis Medications. I do have a disclosure. I am employed by Froedtert Health Pharmacy Department, which is affiliated with the Froedtert Outpatient and Specialty Pharmacies, as the pharmacy department oversees inpatient, outpatient, and then my practice setting, which is considered ambulatory care pharmacy. So before I get into the purpose statements, I want to give a little bit of background. When I started with my role, I eventually developed a template where I go through information with the patients, and I ask a variety of adherence questions to try and get an idea of how patients are taking their medications and any barriers that there may be to remembering to take medications. And so the purpose of this was, one, to describe patient characteristics for those who are considered adherent based on a composite medication possession ratio of greater than or equal to 80%. And that was specifically for medications that fell under the category of cystic fibrosis medications. And then with that information, identify any driving factors for non-adherence and if there were any interventions made by the CF team. So let's go into some of those definitions that are within the purpose statements. So medication possession ratio estimates how often a patient has a medication so that they can take it as prescribed. It is based on claims from day supply history. So thinking about a period of time that you're given. Over that period of time, we count the number of fills and the day supply. And that gives us an estimate of how many days the patient had the medication supplied for over that period of time. And then as you can see, we then divide it by the number of days in that given time period. And then to get the percentage, we multiply it by 100. And then what is common across literature is for majority of medications is to define adherence as greater than or equal to 80%. So in our case, MPR calculated as greater than or equal to 80% was how we defined adherence. So now that we have our definitions, how do we include people? So we looked at anybody that was part of the Freighter and MCW Adult CF Center, 18 and older. In our case, nobody was excluded for being under age 18. And then we wanted to narrow it specifically to people who were prescribed some specific cystic fibrosis medications. We excluded medications such as hypertonic saline, as well as the enzymes, thinking that maybe those products would last longer for patients than their actual day supply was. So an example being with hypertonic, we may prescribe it as 4 times a day with the intent that patients can use it up to 4 times a day. But if they're feeling well, a twice a day dosing regimen is completely appropriate. So if that 1 month supply actually lasts them 2 months, we didn't want that to count against their calculated medication possession ratio. So we specifically then looked at CFTR modulators, so ivacaftor either alone or in combination with one of the correctors, azithromycin to get an idea of that oral medication adherence without having necessarily the same kind of symptomatic impact that we see with the modulators. Getting inhaled therapy, an idea of how that is going based on looking at Dornase alpha, as well as the inhaled antibiotics, thinking specifically tobramycin and inhaled as Trianam. And then our clinic does some other ones like callistomethate. Now that we know who's included, let's look at what we looked at and how we conducted our chart review. So I looked at the time frame from April 1st, 2019 through April 30th, 2020. So about a 13-month time frame. And we used this to gather the fill history. I gathered fill history either from pharmacy reports. Our affiliated pharmacy was able to run a report, and I got some other reports from some specialty pharmacies. I was also able to get some manufacturer reports. And then our electronic medical record actually allows us to load some fill histories. It really depends on what pharmacies are being filled with and the patient's insurance as to whether or not they load. And then if I had some gaps in fills, I would call around to the possible pharmacies the patient could have filled with and ask them to provide any fill history information that they may have. For the chart review portion, I did dive into the charts to look at days hospitalized and days on IV antibiotics during this time frame, because we didn't want that to count against their medication possession ratio. For example, inhaled antibiotics. We would probably have patients stop taking their inhaled antibiotics while on IVs, or they would either stop taking their inhaled antibiotics while inpatient or use the inpatient supply. So I didn't want that to count against their medication possession ratio, and therefore took out those days from the equation. And then when we look at what was looked at for patients where we had that discussion and figured out, okay, what are the barriers to adherence and what kind of interventions were made, that time frame was from May 2020 to October 2020. So what we did is for those patients who had a medication possession ratio calculated as less than 50%, meaning that pretty much less than 50% is standard for non-adherent. If that was calculated for at least one medication, we engaged in a conversation with the patient about it. And then I gathered reasons for non-adherence, and then if applicable, we would perform the intervention. And I would follow up on it then. So what we ended up finding, well, our total patients that fell into this category was 105 patients. And of those 105 patients, 41%, as demonstrated by this pie chart, or about 43 patients, were considered adherent to their medications per the composite calculation. Then if we look at further breakdown based on gender, age, lung function, you can see that none of the values were considered statistically significant, but there were some differences seen. And you can see that patients who were a bit older had a higher percentage of people considered to have good adherence based on a medication possession ratio calculated of greater than or equal to 80%. And then the results continue on here, where I go a little bit more into medications and categories. There are more details in the poster. I did look at medications every which way, but really the big thing to pull out was the CFTR modulators had a pretty big difference on percent of people who were considered adherent. It was higher, or it was pretty high in the patients who were on a modulator. I also looked at genetics breakdown, but that was very much driven by whether or not patients were on a CFTR modulator. So this seemed to be the most relevant section. And then interestingly, patients on alternating inhaled antibiotics had a pretty decent difference too. You see that they're technically both not statistically significantly different, but there is a big gap between 29 and 53% of the patients in each category being considered adherent. So one inhaled antibiotic means that the patients alternate 1 month on and 1 month off, and 2 or more represents that patients have an inhaled antibiotic 1 month and then another inhaled antibiotic the next, and they alternate between those. So then when we look at filling pharmacies, pulling out one filling pharmacy, so patients who only had one filling pharmacy versus those who had multiple filling pharmacies, well, it was much less. So about 70% of patients had more than one filling pharmacy. But we did see that there was a little bit of a difference between if they had one filling pharmacy and multiple as far as the number of people who were considered adherent. And then when we looked at our specific center affiliated pharmacy, those who were enrolled with it greater than 50% of the time compared to less than 50% of the time had a little bit of a difference as well. So now that we know some of the characteristics of people who are adherent and non-adherent to medications, what did we really find out as far as reasons? So with 49 people, we ended up calculating that their medication possession ratio was less than 50% for one or more of their medications. So considered non-adherent to one or more of their medications. And that triggered me or potentially one of my teammates to have a discussion with the patient and find out, well, what's going on? And on average, patients had about 3.8 reasons for why they were non-adherent. Biggest reason being treatment burden. So various things contributing to it, but overall just feeling like their regimen was a lot. Not feeling the medication is needed. And there were various versions of that, but that did make up about 41%. Sometimes it overlapped with that they felt good on a modulator. So about 10 people out of the 49 felt better on the modulator, so maybe didn't feel like they needed to take other medications. Or side effects. So having certain side effects with the medications maybe made it so that they weren't feeling that the medication was giving them as much benefit as it gave them harm. And then time management, just thinking about that treatment burden in addition to getting it to work with their schedule. Maybe with schedule changes, that's when they noticed a lapse, like work changes because of, the pandemic, or maybe with life with children having to manage their schedules, being exhausted at the end of the day, just not really being able to fit it in well to their schedule. And there were several other reasons listed that were a little bit less common, like 10 people or less, but those were some of the big ones. So what do we do about it? Well, as far as interventions go, for 47% of the people, we didn't have anything to do about it. So about 25% of the study total, but of the 49 that we engaged with, almost half of them, there really wasn't much we could do about it. Maybe their insurance required a certain pharmacy that the patient has to fill with. However, in the cases where we could do something, we did. So 18% of those 49 people, we provided education to about how to properly use medications or about the importance. We emphasized the importance of adherence to specific medications just based on where the patient was in their progression or preventative care. And then we also found opportunities to set them up with pharmacy services. So in some cases, I enrolled them with our med management program, or I contacted their specialty pharmacy and found out, hey, you can actually fill this medication through an app if you're finding a hard time coordinating with the team that's calling you, or even pill packaging. So setting them up with local pill packaging services so that they had some memory tools to get the medications and didn't necessarily have to take the time to set up their own pill packages. With looking at the study overall, there were some limitations. I think the biggest limitation I found was pharmacy calls. I called several pharmacies. I had a pharmacy student help me a couple times, and we both had it said to us a couple times where the pharmacy systems just weren't set up well to look back at historical fills. Also kind of interesting is I noticed differences in responses when I called pharmacies. So I'd call and ask information, and then maybe I'd have to call back and because I forgot to ask about a certain medication. And when I called back, I'd get a different technician or pharmacist, and from that, get a completely different fill history. So sometimes I was questioning the reliability of the actual fills. Another part with the pharmacy calls is they were pretty time consuming, on average about 54 minutes per person, granted sometimes more, sometimes less. And then with the interviews, there's the risk that patients would have recall bias, so maybe not remember all the details of what was going on and why they maybe forgot to take a medication or what interfered with that. So in conclusion, there was no significant difference found between the characteristics described. I guess potentially another limitation was it is a smaller population, which we're pretty used to in the cystic fibrosis world. There's a lot of confounding factors present as well. So if we think back to the patients filling with one pharmacy versus multiple pharmacies, well, maybe we're seeing a higher amount of people filling or higher amount of adherence with one pharmacy because the treatment regimen just isn't as complex. So it may be more related to treatment burden, or maybe it is related to just having to call one pharmacy. That makes it easier. A couple other examples of was it this that caused that or that caused it, which is kind of natural for the retrospective nature of how we looked at this information. And then the really good thing that came out of this is I really do feel that we found additional adherence barriers using fill histories to calculate adherence, because I had been interviewing these patients for at least a year before I went through this information with them and didn't necessarily identify this information. So I found that pretty helpful to be able to find additional ways to improve people's ability to adhere to their medications. But now we say improve ability to adhere to medications, but should we prove it? So what I'd like to do in the future is actually look at the impact of the interventions by recalculating medication possession ratios after the interventions were made. As well as I think it would be interesting to go back a year from now where we have our patients all converted to highly effective modulators to see, does that change the landscape of medication possession ratios that are being calculated, and in what way? Thank you for listening to my presentation. My contact information is here if you have any follow-up questions. Otherwise, if you are attending virtually and will be present for the live Q&A, I'll see you soon.
Hi again, everyone. Megan, thank you so much for a fantastic presentation. And we've had a bunch of questions come in from the audience, so I'll start reading the questions for you to respond to. And Megan's poster is number 272. A couple people were asking about that. So I'm going to start out asking the questions in the order that they came in. I think we should be able to get through most of them. So there were a couple of questions about methodology. So the first question we saw come in is just about your literature search and the NPR target or percentage you selected specifically. Was the 80% specific to the CF population, or was there a different way you came up with that number?
Yeah, great question. So there's a lot of great questions coming in, so thanks for having me. I feel like there was so much information that I wanted to share, so to narrow it down to 15 minutes was hard. So with that literature search, 80% yes is generally accepted just across the literature for several disease states with some exceptions. From what I recall, looking at literature that has looked at adherence, it, I believe, was mostly looking at single drugs. They were also looking at about that 80% cutoff to use that definition as well.
Great, thank you. We also had a question about if and how you might have taken into account people who might do things like use auto renewal to stockpile medication or share or donate unused medication among CF family members, how you might have taken things like that into account.
Yeah, so I guess for majority of the medications, with probably just the exception of azithromycin, majority of those would be coming from a specialty pharmacy. So my experience with how they operate is usually they call patients before sending it out anyways. So I did not take that into account, as I did not expect that to be as much of an issue.
Great, thank you. And we saw, I just want to mention a comment come in from Dr. Sawicki that the CFF with the STRC is working on a daily care check-in, which would give us kind of simpler tool to help discuss these conversations in clinics. So that's really great to know. Thank you for sharing that. So we had a question about how patients reported adherence compared with actual adherence. If you're
yeah, so that's so kind of piggybacking off of the previous question about looking at stockpiling medications and autofills. A portion was largely reliant on that discussion with patients. So I didn't actually compare the medication possession ratio to more recent reports, like for the purpose of this project. However, in a little pilot that I did, I looked at probably about 25 patients, and I compared their reported adherence based on my interview with them to their medication possession ratio. And I think I found one person where it actually was kind of close. The majority of them, it wasn't. And so that's kind of what launched me into looking at actual medication possession ratios and allowed me to have a better conversation with patients that really got us. I had interviewed all these people before, and in some cases, yes, I predicted that. It was absolutely in line with how they were like, yeah, I'm not going to take that. And it showed in their medication possession ratio. But with other people, we had a number of people where we were actually surprised to see their low numbers. And some of them, it was explained by, yeah, I have a stockpile from my history of hospitalizations or from them just automatically sending me things. But it did actually give us some surprises with some people, and we were able to, that's where a lot of those interventions came into.
Great, thank you. We've had a few related questions about modulators, so I think we'll go to that next. So let me just summarize what was coming in a little bit. So we had a question about seeing higher adherence perhaps for those on modulators and what might be driving that, and then related, we had some questions and comments about how the impact of Trikafta in particular on adherence to other medications is so important for us to understand. So maybe how would you advise balancing what you're seeing and hearing related to adherence with these modulators, and also being mindful of the fact that we don't really know at this point which medications can be peeled back with modulators, but we also know that people are making adjustments and changing things up. So what advice or I guess what's your perspective on that set of questions, and maybe what advice would you have for teams navigating these conversations and these issues with adherence that are coming up now in the modulator era?
Yeah, I think just taking into account Rana's study before and a presentation I heard yesterday about looking at the patient as a whole and doing a lot more shared decision making, I think is essential right now. Because you can sit there and tell somebody, well, you got to take this, but we want to also have that trust and that honesty with our patients. So if I'm sitting there telling them you have to take Pulmozyme, you have to take Pulmozyme, and I'm giving the rationale and they're just like, I'm just not going to do it, I want them to at least come back and tell me that they're still not doing it so I can make good decisions. So it's finding that good balance. When it comes to the modulators, so we kind of debated how to approach looking at my data because it overlaps with when the triple therapy became available. So that's a big thing to consider. But I did group everybody for modulators together. If you look at the poster, I wasn't able to get into those details here, but the poster does say on an individual basis for the modulators in the different categories that I looked at, how adherent they were. And let's see if I can pull up the number real quick. So for the modulators, they had 78% of people on modulators were adherent. So that would make me suspicious that group was, that medication was driving that composite adherence for those patients. So they were very adherent to that, and therefore that's why we see a higher composite. So I do have that breakdown in the poster. I feel like there was another part of that question that you asked me that
No, I asked you a lot of questions.
It was a little loaded.
So that was a great response. Someone asked if there's any more you can say about the adherence results based on lung function, which feels kind of related to that, and any reactions your team might have had based on, or maybe other markers of health.
Yeah, so I tried to look into lung function in a little bit more detail as far as the breakdown of like mild, moderate impairment and severe impairment. I wasn't able to find anything too different between them. I felt like that was very confounded by several other factors. So I wasn't really able to see a good correlation with it. Hence, I didn't bring up too much different data or dive into it too much.
Okay. Someone asked if you were able to look at all at socioeconomic status or the impact of cost burden on adherence.
I wasn't able to specifically pull that information. We did pull difference of insurances to maybe possibly give us a measure of that. And there was some variance between insurances, but it may have also been correlated with age, where we saw probably our highest portion of patients adherent with Medicare plans. And so we weren't sure how much that was related to that. But I didn't specifically look at that. As far as looking at cost burden, that would have come into the conversations. So some people were not able to get medications due to cost. That was not a huge portion of people. But if that was the case, then we problem solved around it.
Great. I think we have time for a few more questions. We had some questions about follow-up. So a first question is, were you able to follow up with non-adherent patients who received an intervention in order to get their thoughts on if the interventions were helpful or unhelpful? And if you weren't able to provide an intervention, did people have any thoughts about the data that you shared about them?
Yes. So I did try to follow up. In some cases, if therapy was decided with the team to stop, I may have been less likely to follow up with the patients, especially if they weren't already taking it. However, in the case of patients where I connected them with pharmacy services, yes, I did a check-in. And then if there was education provided or anything along those lines, it's been in my standard protocol with my template. If I identify any education needs or set them up with any services, I typically will follow up with them at their next visit. There were a handful of people where I actually called them or I called the pharmacy afterwards to confirm the services were set up. I can recall one patient specifically where I was constantly calling the pharmacy to make sure they were getting her pill box set up correctly. At one point, they changed her CF multivitamin to an Ocuvite. It was crazy.
Great. And another question about future directions or follow-up was just if you had any plans to include an interviewing component like you did in this study to look at the impact of interventions alongside the NPR data, if you're going that way, And then a comment just that it would be interesting to hear from patients about what makes an effective intervention from their perspective.
That's a really neat idea to add to it with what would make an effective intervention. I would like to, I kind of do right now, to start running the data again, but I would like to look at the data, as I had mentioned again, and just kind of see what we're seeing now that we've maybe pulled some medications off of some people's lists, because, you know, that idea of they're just not going to start it, so we might as well reflect things, and they have good lung function in most of those, in all of those cases. And so looking at that with NPR data and redoing an interview, because again, I got a lot of really good information that I don't necessarily feel I get just from asking my adherence questions, having that data in front of them to say, hey, this is what I'm finding. What do you remember being the case or could have caused that gap in fills?
Great. We had a question about if there was any tracking of if patients were members of the same family, with a comment that sometimes non-adherence seems to be like a family characteristic or common in the same family.
I did not do any family tracking specifically, but I was aware of that. Actually, I think we usually see a little bit more contrast in our adult population, since this was very adult specific. So sometimes we'll have one sibling that actually does pretty good with their adherence and another one that maybe isn't as strong as the other one.
Great, thank you. Just making sure we didn't miss any questions. Thanks to the audience for such great engagement so far with this session. Just one final question about anything you might have noticed in terms of trends between mail-in versus local pharmacies, if there was anything you noticed there.
Yeah, so I didn't, again, very few were actually local, with the exception of our local center that had also the med management service, where they proactively call like other places, but they actually review their entire profile. So that was probably our closest thing to having a local pharmacy, because the patients could also choose to pick up at one of our retail sites. But I didn't necessarily look at it specifically. And again, most of them being specialty, that was kind of our closest comparison to the difference.
Great.
Thank you so much.
Yeah, thanks, Megan. And again, Megan's poster is 272, and we can tell this adherence with triple therapy in the modulator era is clearly a topic that's high on all of our minds. So I think we're ready to move to the next presentation. Thanks again, Megan.
I'd like to thank the organisers for asking me to speak today at this conference. I'll be describing our work within the CF Health Hub Learning Health System in the UK to explore the efficacy effectiveness gap for modulators and the potential for inhaled therapy to be a target to optimise outcomes for people on modulators. I have the following disclosures which relate to personal fees for educational meetings and advisory boards. I'd also like to highlight that the NACMO programme of study that I'll mention today is supported by a CF Foundation grant. TRIKAFTA has brought change, bucket loads of change for all of us, and also uncertainty. In an age of transformational treatments, what is the place of preventative treatment, including nebulized therapy? But even in the uncertainty, there are always knowns. And while we are early in our understanding of TRIKAFTA, there is a decade of experience and data around ivacaftor, which may signpost us. So what can we learn from the ivacaftor data? The landmark randomised controlled trial evaluating the efficacy of ivacaftor among people with the G551D mutation found around a 10.5% between group difference in FEV1 over 12 months. There was then a 6-year delay before we were able to access real-world effectiveness data. The real-world data from the US and UK CF registries found a between-group FEV1 difference of only 6% over 12 months. And this efficacy effectiveness gap is unlikely to be fully explained by differences in patient characteristics compared to the RCT, because in the UK, ivacaftor was licensed only for people with at least one G551D mutation during the evaluation. So all people from the UK in the study had a G551D mutation. And around 75% of the US patients also had a G551D mutation. With gene-specific precision medicines, we shouldn't and wouldn't expect to see a big efficacy effectiveness gap. Preventative inhaled therapies were continued during the RCT, whereas there are real-world evidence of declining inhaled therapies use following ivacaftor initiation, which we'll look at later. This may provide a potential explanation as to why the real-world effectiveness of ivacaftor was only around 60% of the efficacy observed in the RCT, where participants are really likely to have maintained high levels of adherence to inhaled therapies. So this is data from a single centre in the UK, and this demonstrates that FEV1 is back to baseline by year 5 of ivacaftor treatment. But this is just one study. And if we look now, we also have systematic review by Duckers. And this looks at the real world effectiveness of ivacaftor, again, highlighting the efficacy effectiveness gap with that wide range of lung function in the outcomes at 12 months. And most of those studies in the review showing an effectiveness of less than the 10.5% that we saw in the clinical trial. Again, we can see here that lung function drops back to baseline by year 5, although still better than those who are untreated. So why could this be? Well, one suggestion is decreased adherence to or effectiveness of the ivacaftor. But if we look at the BMI chart on the left here, alongside the lung function chart, we see that BMI continues to rise by year 5, while lung function drops, albeit that only one large study reported on BMI here. Perhaps this suggests a lung-specific target rather than modulator use that we need to think about in order to gain the best outcomes from the opportunities that highly effective modulators present. Here we start to investigate the place of inhaled therapy. The CF Health Hub Learning Health System provides a unique opportunity to investigate the place of inhaled therapy in the modulator era. The system consists of nebulizers which allow long-term electronic data capture of the inhalation data. This data is presented to the person with CF via web or app access, and the person can choose to share their data with their clinical team, who may access this data via a platform. The Learning Health System of over 60 adult CF centres and a trial paediatric site also provide a community of support to learn together from the data and to use quality improvement to optimise both the data in the system, the processes that best support people with CF to optimise their treatment. CF Health Hub Learning Health System makes the invisible visible. CF Health Hub has a strong RCT evidence base of effectiveness in supporting improved and sustained adherence to inhaled therapy, along with decreased perceived treatment burden, and that was shown in the recently published RCT. The Learning Health System allows people with CF and clinicians to use adherence data to make decisions about their treatment and also to continue sharing their data for research in order to answer important questions like whether taking or not taking inhaled therapy affects the outcomes of people taking modulators. A pattern that clinicians have started to talk about within the Learning Health System and started noticing over the last year is that within a short time of commencing modulators, people seem to be dropping their inhaled therapy, even with severe lung disease. So you can see here an example from a person who started Trikafta on a managed access programme. This was due to severe lung disease with lung function around 20% predicted, assessed for transplantation using oxygen, non-invasive ventilation, as well as optimised preventative therapies such as nebulised Dornase alpha and alternating tobramycin and aztreonam. Within a few days of commencing Trikafta, the person experienced a significant improvement and alongside this dropped almost all inhaled therapy, despite being chronically colonised with Pseudomonas and with an FEV1 of around 50% predicted. And you can see that here with the green line showing that 100% of treatment was achieved, the odd day missing in this first section, and therefore 95% adherence. The arrow showing where the modulator started, and within a couple of days you can see gaps in the data which indicates that no treatment was taken on those days. You can then see some orange bars that indicate that part of the treatment or prescribed treatment was taken in that day, and that sort of moves along until by the end of this graph you can see that this person had dropped to zero treatment. Discontinuing treatment is a theme that is highlighted in the recent UK registry-based paper by Granger et al., who show a decrease in the prescribing of inhaled therapies following the instigation of ivacaftor. So you can see here the red bars on the right-hand side of each of the graphs shows the ivacaftor-treated population with treatment prescribing dropping off following the instigation of ivacaftor in around 2012 to 2013. While prescribing patterns are illuminated by this paper, adherence remains invisible, and it's still really difficult to understand what treatment taking of preventative inhaled therapies looks like in the modulator era. So NACMO is a study programme that's been designed so that the CF Health Hub Learning Health System can work collaboratively to explore what the adherence to preventative inhaled therapies looks like with modulators, and to explore the possibility of this as a target to optimise the effectiveness of modulators. As a stepping stone, the first analysis that we're making is of the data for those who've taken ivacaftor. This opportunistic analysis allows us to learn more about handling the data, optimising the data in the system, and to guide the analysis of the Trikafta data later. While doing this learning, we also aim to generate useful signposts as to what patterns of adherence and outcomes we may see with highly effective modulators. So there were 56 people that were found to be taking or had taken ivacaftor and were in the CF Health Hub Learning Health System. 7 were excluded from analysis, largely due to there being no accessible data for those people. As this was an opportunistic look at the existing data, there was a gap of a median of more than 5 years between the initiation on ivacaftor and the recorded nebulizer doses. And this was due to the start of the CF Health Hub programme being some years after the first availability of ivacaftor. Here we present the treatment patterns for the ivacaftor population within the CF Health Hub programme. In terms of the number of prescribed nebulised medications, around a third of the population had prescribed only 1 nebuliser a day. There was a tendency to prescribing of a mucolytic or osmotic only in the ivacaftor treated population, and we plan to explore the impact of prescribing further by calculating effective adherence, which is based on current best practice, being that those with chronic Pseudomonas are prescribed an inhaled mucolytic and an antibiotic, and calculating the adherence based on this ideal prescription. Adherence levels are significantly lower than those we expect to see in clinical trials, at around 55% adherence to prescribed treatment versus in excess of 80% adherence in clinical trials, which was identified in the Pugac paper, Adherence Patterns to Study Drugs in Clinical Trials by Patients with Cystic Fibrosis. We expect that our result may still represent a higher level than that present in the wider ivacaftor treated population for a number of reasons. So we've not yet calculated effective adherence, that adherence based on the recommended prescription. Our group have demonstrated that different methods of reporting adherence can result in different magnitudes of adherence. So we suspect for that reason, this 55% adherence to the prescribed therapy may be even lower in reality. This result is also based on people engaged in the learning health system and whose data was accessible. And our group have demonstrated that those with hard to reach data are largely the group with very low, less than 10% adherence. Therefore, this missing data is really important. Lastly, the median age is 27, and our group, as well as others, has demonstrated that adherence is higher with increasing age. So in these older patients and engaged patients, we still see markedly lower adherence than that identified in the clinical trials. So are we squandering the possibility of normal life expectancy? Preservation of lung function is one of the most important outcomes and aims for people with cystic fibrosis. If we can alter the course of lung disease progression early in the disease course, it can be really effective for long-term outcome. So we can see here in the Rowe paper that, for example, by reducing the average rate of decline from 4% to 3% per year, starting at 20 years, the long-term mortality or need for a transplant would be expected to be delayed by 6 to 8 years. Of course, the reverse is true if we observe and don't act on declines. Can we do something different to see a different 5-year outcome in Kaftrio than we appear to be seeing with ivacaftor? Should we tolerate this gap, this efficacy effectiveness gap, with an expensive and highly effective gene-specific precision medicine? And that gap in adherence to preventative and health therapies with ivacaftor is shown between the clinical data, the clinical trials data, and our real-world data. CF Health Hub provides a unique access to pre and post initiation adherence data for Trikafta going forward. And that is what we will be looking at with NACMO, with these aims of looking at the real world effectiveness, the gap, and changes in adherence and what the impacts of those changes are. Ultimately, our aim is to help to answer the important questions people with CF are asking of us. In order to answer this, CF Health Hub are able to use the data generated by people making their individual choices about stopping or continuing preventative inhaled therapies. We can observe the outcomes of their choices and understand what becomes of people who continue or stop treatment. I'm presenting this on behalf of CF DigiCare, which is the CF Health Hub Learning Health System. It really is a village, and I'm standing here representing everyone there. Our contact details are on our final slide if you'd like to understand more about the programme. Thank you.
Great. Thank you so much, Tracy, for a very interesting presentation. And it's great. Carol and I were so excited thinking about the in-person meeting, but I think it translates to virtual as well, to have representation from not just the US, from across the globe. And it gives us lots of interesting things, I think, to think about and ponder in this as we move into this new era of CF treatment in a number of ways. So we've had a question come in through the chat, and then a couple questions to follow up. So we'll start with the questions from the chat. And the question is, Tracy, whether you were able to query the participants who were on ivacaftor on possible reasons for their lower adherence to their daily nebulized therapies.
Yeah, absolutely. I think this is going to be really vital, really understanding what the drivers are behind the different levels of treatment taking. It's not something we've looked at yet, but it's definitely on the radar to be doing that. At the moment, the big focus for the programme has been around the data quality. So we've done quite a large piece of work on that, and really using our community and our learning health system to understand that data in the system. because obviously, as I've explained within the talk, depending on the group that we capture, within that data that we capture within the health system, that can affect the adherence levels quite a lot. We're really keen that we reach the hard to reach people so that we get accurate adherence levels as much as possible. So that's really been our focus up to now. And then this is our preliminary data, really, to understand just that adherence level. And then the next steps will be, we have our initial 6-month snapshot of pre and post CAF trio, and then we'll be starting to really think and engage with the reasons why and what's happening for people who make these different choices. I think for us that last slide is really important around kind of actually, if we have someone sat in front of us in clinic who's saying, you know, what becomes of me if I continue my treatment, or what becomes of me if I stop my treatment, that is so important for us as clinicians to be able to answer that honestly. So at the moment, our engagement with people with CF in the health system is around really encouraging that sharing of data so that their choices can give us some of the answers for their future selves. So not yet, but definitely on the radar.
Yeah, thank you, Tracy. And I loved that slide as well, and wanted to kind of pose those questions back to you. So knowing that none of us have a crystal ball and we can't be ahead of the data that we don't have, how would you advise that we handle those conversations in clinic? What are you saying to patients who are asking those questions when they come for their appointments?
Yeah, absolutely. I mean, I think it's really important, isn't it, that we respect people's choices at this point, that we reflect the data that we know as clearly as possible. And I think we know that the signposting from ivacaftor is perhaps telling us that there's something going on lung-wise that maybe means that we're not optimizing the effects of those highly effective modulators. We don't yet know what that is, but there's every potential that it's something that's different between what's happening in the real world and what's happening within what happened within the clinical trials. And therefore, you know, our best thoughts are that inhaled therapy, or certainly some of the other therapies that target the lungs, may be having an effect here. We're lucky in that we are a CF Health Hub centre, so we're also able to reassure patients that whichever choice they do make, by contributing their data, they're contributing to our citizen science to understand and be able to use that choice to influence choices in the future and to improve that knowledge.
That's you know, that's such a great point. And I think we had a question just come in about how you might convince patients who are struggling with adherence to be transparent in sharing that information. And I love that idea of maybe framing it like you're helping us answer these questions for the future. Do you have any other thoughts about how you might encourage that openness and those conversations?
Yeah, I mean, I think this is where actually being a clinician researcher really helps to influence some of these conversations. So I do encourage clinician researcher pathways, because I think it really does help us to make this real for patients. And absolutely, I think what we've just discussed is certainly my bottom line, and I think the bottom line for most people within our learning health system, around being very honest that we're in a period of uncertainty, that actually even for those of us who've worked in CF care for decades, it's uncertain for us too. That actually some of our best reasoning from the evidence may be that actually we think that treatment should continue as they did in the original clinical trials, but that their choices are respected and their data and their honest views can really help to influence our knowledge about this in 3, 4, 5 years' time.
That's great. And just a quick sidebar question before we get back to this. We had a question about if the CF Health Hub in the UK is the equivalent to the US CF registry. I don't know if you know the answer to that, but
yeah, no, we do have the UK CF registry,
okay.
which is also a really helpful database of information. The Granger paper that I included in my talk, which looked at prescribing data pre and post ivacaftor, that is using our UK CF registry. CF Health Hub is a separate programme of research led by Dr. Martin Wildman, and it is a learning collaboration which of around about, I think we're now at around 17 centres, adult centres within the UK, and also being trialled within paediatrics, which really focuses on inhaled therapy data. So it has a learning community within it, but also focuses on electronic data capture using e-track nebulizers and using that data to influence both for research, but also to use as a clinical tool to assist with thinking about adherence in clinical practice. I mentioned the paper that's just been published in the last few weeks within Thorax, and that paper actually demonstrates that using the CF Health Hub programme and the habit formation interventions based on the COM-B model, it's actually shown a significant increase in adherence using that system, and also a decrease in perceptions of treatment burden as well. So well worth looking at if you're interested in treatment burden as well. Great,
thank you. So a related question to the bigger adherence conversation is just thinking through, is it lower adherence versus a different prescription or guidance from the clinician? And if there's some kind of shared decision to stop a therapy, then, is the person really non-adherent? And how do we account for that when we're looking at these questions?
Yeah, this is such an important question because it comes back to measurement as well. And this is absolutely something that we've grappled with within our learning community. So I mentioned within the talk that we haven't yet calculated effective adherence, as we would call it. And we feel that using effective adherence as a measure is really important because it takes some of the prescribing nuances or variation out, because you're absolutely right. What some of us might do is, if we know that someone isn't going to take something, we stop that prescription, right? But then what we end up with is, let's say we've got someone who's chronically colonized with Pseudomonas. The current guidance would generally say that that person should be on at least 1 mucolytic DNase and 2 inhaled antibiotics a day. So that's 3 treatments a day. Might vary a bit if you're on casein or whatever else, but let's take 3 as a minimum. If then actually a clinician decides to stop the inhaled antibiotic, someone's not taking it, we're then measuring that person on 1 neb a day. So someone doing 1 neb might be getting 100% adherence, whereas the equivalent patient with a clinician who hasn't stopped it may only be getting 30% adherence. So we feel it's really important to calculate effective adherence as well as kind of unadjusted adherence, which was presented today. In order to do that, we need the Pseudomonas status, which we haven't yet calculated for everyone within the system for this study, but that will be one of the next steps to look at. I think thinking about the way that we calculate adherence is a really, really important factor.
Yeah, thank you so much for that, and agreed it is important in thinking about how we're tracking data in these registries and what's being prescribed versus those informal conversations in clinic is something we're definitely going to have to grapple with. I think you've touched on this. The last question you haven't addressed yet, I think you've touched on this a little bit, but just pose it to wrap us up. We had a question about just if you think that the decreased adherence to the nebulized meds, including antibiotics, pulmozyme, hypertonic saline, if that is primarily responsible for the return to baseline FEV1 after 5 years that you reported.
That is the target that we're focused on, most definitely. And you know, as researchers, we still have that balance of, you know, we may be incorrect in our target here, but we need to choose a target that we can really think about. And the electronic data capture that we have within the CF Health Hub system is a unique data set, as far as we're aware, that has that data for pre-Kaftrio and post-Kaftrio. So this is going to be a way that we can answer that question, and that most certainly is currently our target of thinking that this is a real possibility, that the reduction in our maintenance inhaled therapy is meaning that we're not realizing the results that we saw in the original clinical trials for highly effective modulators. And I think that's something that we all want, is to be able to realize the full benefit and to maintain that benefit for as long as it's possible.
Great. Well, thank you so much, Tracy. Fantastic talk. And again, thanks to the audience for such great thought-provoking questions and prompts. I think we're ready to move on to the next presentation.
Thank you so much, Kim.
Hello, my name is Saida Hussein. I'm with Spark Health, and today I'm going to talk to you about the development of a PERT smart pill holder. I have no relationships to disclose related to this presentation. So with that, let's get started. Exocrine pancreatic insufficiency, or EPI, is caused by a reduced inappropriate secretion or activity of pancreatic juice, its digestive enzymes, pancreatic lipase in particular. EPI symptoms include malnutrition, abdominal pain, and diarrhea, and is associated with increased risk of mortality in patients due to cancer, infections, and cardiovascular events. Approximately 75% of infants with CF have EPI. The treatment of EPI involves dietary management, lifestyle changes, and pancreatic enzyme replacement therapy, or PERT. While PERT helps break nutrients down in food, there are barriers for some individuals in ensuring they're taking their enzymes with food. For example, they may forget, they may not have their pills with them, they may be embarrassed of taking them, but for whatever reason of why they're not taking them, by not taking them, those people may suffer painful consequences. So this lack of adherence to PERT has been tied to worsening of disease, as well as increases in hospitalizations and emergency department visits. The barriers with consistent PERT include the complexity of the regimen. So multiple pills are needed in conjunction with both snacks and meals, and the number of pills needs to be adjusted based on fat content. So for the current study, we're interested in the development of a portable pill dispenser that's compatible with smartphones and has the potential to ensure that patients are able to take their enzymes. So really what we're after here is a pill dispenser that is also connected to one's smartphone and just can help patients ensure that they're taking their pills so that we can avoid some of these negative consequences that we've discussed. So in a survey that we conducted in late 2020, we asked 240 CF patients how valuable an integrated solution like this would be in helping with their PERT adherence. Majority of participants said it would be very valuable or extremely valuable for them. Using a subsample of the original 240, we randomly selected them and asked them if they would participate in a 45-minute interview. In total, 10 participants agreed to be part of the interview, 8 women and 2 men. So we have women slightly overrepresented here, but quite a nice age range. So we go all from 21 all the way to 80 that's represented in this group. And we also have many regions across the United States. So we have the West, the South, Northeast, etc. So participants completed a semi-structured interview that addressed the known barriers the ways in which a structured program could help them, and the viability of a proposed device. So we also wanted to ask them a little bit about, what brought them here, the history that led to their diagnosis, what their dosing regimen currently looks like. If they make adjustments, how do they do that? How is their adherence? How does that work? How does that look for them? As well as we also had a few different prototypes of the device. So we had it in, square, circle, different shapes, sizes, forms, and also different types of dispensing. So, through a button or through some type of GUI to release the pills, and just really ask them, based on their lifestyle, what would be the most helpful for them, and what would, sort of enable them to be able to do all the things that they need to do and ensure that they're taking their pills on time. So they rated those features and they told us what they most wanted to see. And then we kind of asked them to expand on why, and just talk a little bit about that and why they chose what they chose. We also asked them about different interactive features. So whether they were interested in, playing games with other people on the app, or, some kind of like fun competition that would help with that, what kinds of educational, content would be helpful or useful for them. So we tried to just sort of think about all the things that could encompass this pill dispenser and the compatible app, so that it would most enhance their experience, and again, assure adherence. So what we found is that the majority of participants selected the reminders to take the pills, either to take their enzymes, to refill the prescriptions, and refill the dispenser as the feature that they like the best. So, sometimes they talked about, leaving the house and not having their pills with them, or forgetting to refill a prescription, or even just if they take the dispenser, or, sometimes they would just kind of ball up their enzymes in like a little tissue and take that with them. But having a dispenser, they would like some kind of feature that helps them to remember to refill the dispenser as like their top feature, followed by the feature that assists them in calculating doses. So participants discussed a lot about, how they kind of had to play a guessing game, and that they sort of had it down to like their science based on what they were eating. But of course, it's imperfect science. And so sometimes, their own calculations backfired on them, and they suffered, some of these consequences that we discussed earlier. So that was a really, big thing that they thought would be really helpful for them. Participants also expressed being comfortable with the information being sent to doctors, which was, we weren't sure what to expect with that question, but we were pleasantly surprised that people were so excited to be able to share this data. But they talked about the fact that, their visits were so far apart from each other that, being able to have all this data right there for their doctors would be something that would be huge for them, because, it could also help to say, well, I took X, number of enzymes with this snack and it didn't work out. So how can we, recalibrate here and, move forward for like more successful intervention? What some participants were unsure about was whether or not, doctors would have time to look through all that data. Of course, 6 months of data would be a long time, but even being able to pull it up in the middle of an appointment and kind of go through, what some of the most important dates or data or events are, could be helpful for them, in when they think about their care with their physician. Many participants expressed that they also wanted more about people's lesson learned. So they talked about the fact that they can't get enough, they're in groups, and as much as they can, they try to read up on, their enzymes and what people's, experiences have been. But what they really wanted, was to learn about what other people had been doing through this app. And so, maybe some people weren't so excited, for example, about games or things like that, but they really wanted to be able to just, learn about what was going on with people, what worked for them, and what they could possibly take, for themselves, to be able to like make that work for them. Participants also discussed the fact that, they wanted something small that they could carry either in pockets or purses. We did have a little bit of a difference when it came to age. For example, the younger participants with children wanted something where the pills were a little bit harder to dispense because they didn't want their kids getting in there and, having hold of their pills, whereas the older participants wanted something easy. They didn't really want to have to fidget with it. So, we have a few, considerations and things to think about as far as that. But overall, participants, I think felt like they had their established family networks and no one really felt embarrassed about taking their pills. So it didn't really matter that the dispenser had to be like really tiny and discreet, but more so that it was important that they A, remember to take their enzymes, and B, had the right amount of enzymes, to take with their meal. So the information collected was used to gain insights regarding adherence behaviors, the features, of the mobile device, what they liked the most, the lessons learned, for example, being able to share that data with their doctors and healthcare providers, and just like thinking about what functionally would work best as far as getting pills and being able to take them easily. And so now we've moved into the prototype development stage of the smart pill holder for PERT, and just wanted to give you a little bit of a preview of kind of like what it's looking like now. You see here we have kind of a little knob to help dispense, and just being able to have a good amount of enzymes so that you're not sort of running out, in the middle of nowhere. So that's all that we have now. Thank you so much.
Great, thank you. Thank you so much. It's really neat to hear about this, and thanks for showing the prototype. That was really cool to see. To kick us off, we just had a question from the presenter panel about the chat feature within the app. If there was any monitoring in the chats, and how any misinformation or suggestions that might not be accurate are handled or monitored.
Thank you so much for that question. That's a really good question. I think at this time, I'm not sure if we've really looked into it or thought about it, but that's actually a really, really good point that I'll take back. I think we were just more thinking about it as just like a way, people talked a lot about just wanting to learn about through other people's experiences, I think was the most important feature. But of course, in this day and age with misinformation, I think that's a big one to think about and consider for sure. So thank you for that question.
Thanks. And we had a question just come through the chat about whether you were able to identify any differences in desired features of the app based on age or life stage, and maybe we can generalize that a little bit just to thinking about tailoring more generally based on different variables like that.
Yeah, definitely. I mean, I think for sure that came up. Of course we had a smaller sample size. 10 is, not very big to generalize to, but that for sure came up. I mean, I think I mentioned it, some of the moms were concerned that their kids might get in there, or pets, or, like that there would just be like the potential for the pills to kind of spill out and go and be everywhere. Whereas, some of the older participants, worried that they didn't want something that would be too hard to try to get into. And so we had some differences there. But I think, and I mean, similar to what we've heard with some of the other presentations, I mean, it seemed like some of our older participants were doing a great job anyway, as far as like adherence. And so this would be just something that they would be able to like kind of like take and put in their purse or in their pocket and just take on the go with them. But that's what I would say was the biggest difference that came out in terms of age ranges.
Great, thank you. And maybe to extend that a little bit, we had a related question just about your opinion about if the insights on adherence or what you learned might be any different if you were to go to a younger teenage or younger population.
For sure. I mean, I think sort of to, maybe guess a little bit, I think, just even based on like what some of our younger participants were saying, it would be that some of them were a little bit more embarrassed about, having to like stop in the middle of, or, before a meal to like take their pills. And so they mentioned that being able to have a smaller sort of pill holder would be nice because they could kind of hold it under the table and like sneak their pills. Whereas our older participants, there was no embarrassment there. They were kind of like, yeah, I mean, my friends know me. They know what I do. They know that I need to take my pills and like, I'll just take them. It's no big deal. So, I mean, I would guess that maybe with teens that the compactness of the pill holder would be important, just because they may not be ready to like really discuss with their friends what does this mean and why am I taking this, and all the implications behind that.
Sure. So a couple questions just about the actual apparatus, like the size of it, if there's a specific brand, just kind of a little more like logistics, if you could, about the actual dispenser.
Yeah, so it was fun. We had somebody that kind of did a mock-up. We had different shapes. So we had kind of like the circular, the ladies might know, like the little like birth control pill pack, like the circular, kind of like that, or the makeup packs. But we also, the most popular one ended up being the like little square one. So kind of like the earbud, the iPad earbud holders, kind of like that size. So it's really small, compact. That ended up being the winner. People preferred it the most. And then we also had kind of like a long, more like a Pez dispenser, like a rectangular one. And that just seemed too big and bulky. And then I think some of the guys were like, well, the other one looks kind of like a birth control thing or like a makeup thing. And so in the end, the little AirPad iBud thingies won.
Okay, great. And a question about how frequently users were engaging with the app, if you have that data available.
Unfortunately not. So this was even just to see if, this would be something that like would be feasible, like if people wanted it to be connected to a smartphone app. And I think overwhelmingly, except for one participant who I think she said that she doesn't have a smartphone, I think everybody else was pretty on board and, wanted to have that feature. Maybe not to like, we had proposed like maybe interactive like games or something, and some people were like really for it and some people like didn't want any kind of competitive components to it. But it seemed like just overall they just wanted somewhere where like like they could just chat with other users and see what other people were doing.
Great. And a few questions just related to cost and potentially ordering something like this for patients. And I think that's showing the enthusiasm for the idea. I know it's still in the prototype phase, but maybe just to wrap up, you could just talk a little about steps for potentially integrating something like this into clinical practice, what that might look like.
Yeah, so I think we were really excited that people were so enthusiastic about being able to share this information with their physicians. Of course, right? Like that's like time burden on the physicians and all of that. But I think that people were so willing to, I think we were trying to find ways to think about how to incorporate that into like Cerner or Epic, depending on, which system people are using. And so I'm sorry, I think I like got off track of the question. But yeah, so I think we're in the prototype stages still and still like working out the kinks, but I think definitely it's very exciting to see all the enthusiasm for sure.
Yeah, that's great. And people are sharing ideas about customizing and designs and colors. So that's it's great to see the engagement around that, and a really cool idea with a lot of future opportunity and potential. So thank you so much for sharing. And I think we're ready to roll our final presentation.
Hi, I'm Scott Taylor, and I'm the CEO and co-founder of Perks Health, and I'm here today to present our abstract, Improving Medication Adherence and Patient Engagement in Cystic Fibrosis. We've undertaken a retrospective analysis of a mobile application, Perks Health, utilizing gamification and incentives. First and foremost, I should present the obvious conflict of interest disclaimer and disclosure that I am the CEO and co-founder and a major shareholder in the company Perks Health. And the retrospective analysis that we've conducted and that we're presenting today is of the mobile application Perks Health being used by cystic fibrosis patients. So with all that disclosed, what I'm hoping to cover off today is provide a bit of background about Perks Health and what we've built. As well as our work with cystic fibrosis patients in the commercial setting in Australia, provide an overview of the retrospective analysis that we've conducted on the data we've collected from that work and explain some of the results. And then I'll be participating in a Q&A session following this recording. To provide a bit of background on Perks and the intervention itself, I think it's probably worth us covering off something that anyone working in cystic fibrosis will be pretty familiar with, and that's that daily adherence and engagement with critical self-management tasks can be a major barrier in managing cystic fibrosis. And you only have to look at a number of the tasks that are routine in any cystic fibrosis treatment plan, from medication to physiotherapy, taking supplements. And you see some worrying trends in terms of adherence. So 50% or thereabouts adherence to the various tasks that someone needs to complete as part of a cystic fibrosis treatment plan. And perhaps not surprisingly, low adherence is correlated with more hospitalizations and higher costs of acute care. And this is pretty consistent with what we see across a number of different chronic conditions. But it is worrying that in a condition like cystic fibrosis that we see these trends in adherence and engagement. And it's particularly prevalent in adolescents and young adults. To fight the challenge of adherence, a lot of tools and digital technologies have been developed, from medication apps to physiotherapy devices, to try and improve adherence, engagement, and education. But the unfortunate reality is that we do know that patients often struggle to adopt, engage, and consistently use these tools. So with a typical digital care program, we see a 5 to 10% enrollment rate. And then even those patients who do enroll, we typically see them engaging at a 14% daily engagement rate. To provide a bit of context there, that's around engaging once every week or 2 weeks. And then when we look at the long-term use of digital interventions around adherence and treatment plan management, we see around 2% retention at the 6-month mark. And this was actually from a study run by Apple in digital health for managing respiratory conditions. Perks Health, which is the company that I founded about 5 years ago, and the technology that we developed, adopts a slightly different approach and prioritizes sustaining engagement first and foremost, and that means patients recurringly using our solution, and then uses that engagement to drive adherence and outcomes. And so we're heavily focused on how do we get patients to enroll, consistently engage multiple times a day with our solution, and do so over a long period of time, because we know if we can get that attention and that engagement, we can drive adherence to critical treatment plan tasks. And in doing so, if we can get people to adhere to treatment plan tasks over an extended period of time, we know that will ultimately deliver outcomes. And the way we achieve that and the way that we focus on engagement is slightly novel. So we use a range of different strategies to engage patients in digital technologies. They can consist of gamification, community, habit coaching, challenges, and rewards. And we successfully see those interventions and behavior change strategies engage patients 4 to 5 times a day using our Perks member app. And the Perks member app is what the retrospective analysis was conducted on with cystic fibrosis patients. What we do find is that once we engage those patients 4 to 5 times a day, we can drive consistent adherence with those patients. And we do have clinical research that demonstrates a 90 to 95% plus adherence rate with a wide range of different condition areas. Indeed, as I mentioned, we've now published multiple peer-reviewed papers with research journals such as the British Medical Journal, the American Journal for Managed Care, Journal for Medical Internet Research, and presented posters at a number of conferences, including ESPACOMP, the premier conference for adherence. Across all of those, we've focused on a wide range of condition areas, so far beyond cystic fibrosis. We've run a randomized controlled trial with the University of Sydney looking at complex diabetes and cardiovascular patients in the public healthcare system in Sydney, Australia. The trial was run by the University of Sydney, and with a complex cohort of publicly insured patients. The average age was 60, and ultimately they kind of were polychronic and had quite complex treatment plans. The results of that trial have now been published. We saw a material improvement in adherence in the intervention arm versus the control, as well as statistically significant impact on biomarkers at various points in the 12-month observational period. Taking that research that we've conducted in other condition areas, we started working with Cystic Fibrosis Australia, which is the leading national foundation for cystic fibrosis research in Australia, back in 2018. We were working with them to build a digital chronic care program and adherence program for people living with CF all around Australia. Over that time, we've now seen that program grow and through successful marketing campaigns in combination with Cystic Fibrosis Australia and some other partners. We've now enrolled almost 1 in 3 people living with cystic fibrosis in Australia. So over 1,000 patients have enrolled, and the total population of Australia is around 3,500. The total cystic fibrosis population is around 3,500. Those patients are recording an average adherence of around 87%. And using perks consistently throughout the day, and indeed on average 4 to 5 sessions a day, and a really high level of patient satisfaction, which I think is important for maintaining long-term sustained adherence. For the purposes of the retrospective analysis that we've run and we're presenting as a poster in the conference today, we decided to run a retrospective analysis on a subset of patients in that cystic fibrosis program who were using perks to manage their medication, look at the medication adherence rates, and also look at the kind of enrollment rates and engagement rates with the program, as well as any patient-reported outcome measures that they were recording. As part of the Cystic Fibrosis Australia partnership, we do work to help conduct research around patient-reported outcome measures and identifying certain research gaps or support gaps that exist with their population. So the retrospective analysis was set up to improve and investigate and the analysis and the impact of mobile app perks health, utilizing multiple components of gamification, incentives, reminders, and social community, and the ability for it to improve medication adherence, assess the enrollment uptake rates across the program, and the success in collecting patient-reported outcome measures in patients with cystic fibrosis. The sample size of this cohort was at just over 1,000 patients, at 1,004 participants living with cystic fibrosis. The observational period that we took was the 27 months that we'd run the program for Cystic Fibrosis Australia to date, and we were recruiting those patients through Cystic Fibrosis Australia's social media presence, newsletters, and other cystic fibrosis healthcare providers. So we have a few partnerships with hospitals and cystic fibrosis clinics and nurses who are helping recommend the cystic fibrosis program to those patients. The key outcome measures that we're focused on was enrollment rate. So how many signups were we able to achieve in the Cystic Fibrosis Australia Perks program as a percentage of the Australian CF population? The average adherence rate, and that was actually being measured through mobile direct observational therapies. So through the Perks member app, we actually asked the patients to take a photo of the medication at the time that it's due, and then take the medication as prescribed. And then the final kind of outcome measure was the number of patient-reported outcome measures collected via daily in-app surveys. So there were specific questions, and I'll obviously cover off some of those questions as what they were, but generally asking them about how they were managing their cystic fibrosis. The results over the course of the study and over the period that was observed was that participants had on average 84% adherence to their medication during that time period. And yeah, this was driven by the high level of engagement that participants had through the Perks app. So on average, they were engaging with Perks, the Perks member app, 5 sessions a day. For an average, only 1 minute to complete a session, which is effectively taking a medication or logging a physiotherapy session. And we're in the app for 1.5 hours every month. So that shows just genuine and sustained engagement that enabled us to ensure that they were completing medication tasks and achieve that fantastic level of adherence, as well as collect patient-reported outcome measure surveys. So over the course of the study, approximately 46,000 patient-reported outcome measures were collected. So these were specific data points around how people were faring with this cystic fibrosis management. And on an average, we're pushing around 5 PROM surveys to each user each week and keeping them sustainably engaged. And indeed, actually 86% of users that were active at 1 month were active well beyond 3 months. And so we saw that those users who had really formed a habit around using the Perks member app were sustainable long-term users of Perks. What's more, over 73% of participants in that trial found and agreed with the statement that Perks is helping to improve their cystic fibrosis. And I think that is really important. Whilst, as with any health intervention, it's not just important that it has an impact, but it's important that patients realise it's making an impact. And so it was fantastic to see that recognition from participants in the study. And finally, I mentioned some of the PROMs that we collected. We've collected over 46,000 cystic fibrosis PROMs through the program to date. And these looked at questions such as how they were breathing, how they were eating for the cystic fibrosis, mental health question around the fullness of the day and enough energy for exercise. And we've been able to kind of share some of those aggregated insights back with Cystic Fibrosis Australia to help them dictate their research and their support programs that they run for Cystic Fibrosis Australia members, of which a large proportion of people living with cystic fibrosis in Australia are members of Cystic Fibrosis Australia. So in conclusion from the retrospective analysis, we've drawn that gamification and incentives can increase intrinsic motivation and patient empowerment through those extrinsic incentives. Mobile technology can be an effective intervention, increasing patient engagement, improved medication adherence, collecting PROMs, but we do think it needs to be done in the right way, in a way that drives engagement first and foremost, that translates to adherence. And I think the other fantastic result from the retrospective analysis was identifying with over 1,000 participants recruited into the trial that effectively represents 1 in 3 of the Australian cystic fibrosis population. But the most rewarding part of the retrospective analysis was some of the qualitative feedback we received from a number of the participants in the trial. Everyone from Ben, 6, whose mother kindly passed on her thoughts on the Perks health intervention, stating that Perks is a lifesaver, it's helped so much with her compliance, that he's proud to complete his treatments and feels empowered to complete his treatments, and also the enjoyment of earning gift cards and the assistance that are provided in providing that care to Ben. I think importantly, we also saw great engagement and adherence from people living with cystic fibrosis at the other end of the spectrum. In Ali, who's 31, she's managing 2 hours of treatments a day and up to 40 tablets that she needs to take. But she, after hearing about Perks from the medical team, is more motivated to keep up with her treatments and more vigilant about staying compliant. And also saw benefits in in actually being able to save money with pharmacy gift cards. I'm very grateful for the ability to use that to actually purchase her medication and other aspects of the treatment. And I think that's really fantastic to see. If anyone would like to learn more about the retrospective analysis, about the program that we run with Fibrosis Australia and Perks Health more generally, we'd love to chat. My best contact details is scott@perkshealth.com. My mobile phone number is on the slide there. And I'll now hand over to Q&A. Thank you very much for listening.
Great. Wow. Thank you so much, Scott. Lots of great questions coming in from the audience, and it's pretty mind-blowing the level of engagement you're reporting on. So I think we have about 10 minutes left. We should be able to get through most of the questions. And I think they're kind of falling into a logistics category, and then some questions more about how the app works and next steps. So maybe we can just start with some of the logistics clarifications. So a couple people commented that maybe they missed this, but would you mind just clarifying the kind of target age range, if there is one, for the app?
Sure, and just checking everyone can hear me okay. Great. Yeah, absolutely. And sorry, I should have probably clarified that in the presentation. What we have found in our work with Cystic Fibrosis Australia and obviously cystic fibrosis patients is that whilst we kind of recommended that it was for ages 12 and above, we also had a bunch of parents downloading the app to then use it to manage and motivate their kids who are younger. And Ben's obviously an example of that. You know, the primary user there is actually his mother. But she kind of uses it to manage his medications and his therapies. And I think, you know, as you can probably see from the testimonial, allows him to kind of get a bit more engaged and exciting in his treatment plan. And so, yeah, generally we say, yeah, the primary users should be 12 and above, and that's what, yeah, the kind of app store requires. Yeah, whether we don't allow anyone younger than that to download the app. But we do see, you know, those stories and user feedback coming through around, yeah, parents using it to manage their children who are younger than that.
Great. And acknowledging that there are differences between countries and all of that fun stuff. A bunch of people are asking, is this Australia specific? Can you download it in Canada, in the US? Kind of thoughts about going beyond Australia, what that might look like, if your team has thought about that at all.
For sure. I'm at well, despite my thick Australian accent, I'm actually based in Chicago, Illinois.
Oh,
so no, that's right. No, and I've only recently moved over, and obviously, you know, Perks is very much an Australian company and launched in Sydney. We have started working with a number of health plans and healthcare systems in the United States, and we're looking about how we can deliver a similar program to what we delivered for Cystic Fibrosis Australia in the United States. Also saw Canada on there. I'd love to have a chat with anyone from Canada. Particularly because I'm a lot closer in Chicago than I was in Sydney, Australia. So no, we'd definitely love to do that, to kind of explain some of the funding, because I know that there's a bunch of questions there, and that's probably relevant to, you know, is it available in the US or is it available in Canada? So actually, you know, Perks is funded by Cystic Fibrosis Australia for anyone living with CF in Australia. And that's part of kind of some of the research grant and commercial grant funding that they have. And so, from that perspective, for patients in Australia living with cystic fibrosis, Perks is entirely free to use.
Great. Yeah, you read my mind. There were a lot of questions about fees, both from the patient side, if there are any fees for enrolling and keeping the app, and then from the side of funding the incentives and that sort of thing, just how that's supported and where that money comes from.
Yeah, absolutely. And so currently that's effectively Cystic Fibrosis Australia is providing the funding to Perks to provide it for free to anyone living with CF in Australia. Great.
That's pretty amazing. People are just asking about how the adherence data is collected and measured. Is it self-report? Does it interface with anything more objective?
Yeah, so we actually require that patients take a photo of the medication at the time that it's due, and that has to be a live photo. So I guess we'd call it mobile direct observational therapy, which has been used and kind of completed in various other pieces of clinical research and shown to have a good correlation with actual medication taking behavior. We have run a study outside of cystic fibrosis, our randomized control trial that I referenced, kind of the background section with the University of Sydney, where that was actually that the rates of adherence that were recorded in the app were compared to actual pill counts done at various intervals. And that was a close correlation between both, our adherence data, mobile direct observational therapy through the app, as well as the actual pill taking behavior, or medication taking behavior. And so I guess, to an extent it's self-reported, but it requires some validation that they have the medication with them at the time.
Great. Thanks for that. A question just I think we see with a lot of apps, there's often a lot of uptake initially, and then it kind of peters off as people have it for longer and longer. So just a question about if there is any data on short-term versus longer-term uptake, I guess what you know about engagement over the course of time.
Yeah, no, it's a really good question. And I think there is this assumption that because something is digital, it should therefore be as engaging as some of the digital solutions that we use. And that's definitely not the case. I mean, when I kind of was pointing out, there's, Apple ran a digital health program for an asthma digital intervention and saw only 2% of people were still around after 6 months. Perks in comparison sees around 50% of users still actively using Perks day in, day out after 6 months. I'd have to go and look at the specific data for the cystic fibrosis cohort to give you a kind of accurate answer there. I don't have that on hand. But we do see a much higher level of retention and engagement ongoing with the Perks app versus other digital health solutions.
Wow. Yeah, that's very impressive. A couple people are asking just if you could talk just a little more about the gamification aspect, how it actually works in terms of, what it's like, what the reward schedule is like, earning incentives, that kind of thing.
Yeah, I guess philosophically at Perks, we believe or location or age, it's really driven by just fundamentally what motivates them as a person, and what motivates you may be very different to what motivates me. We take an approach that we offer a wide range of motivators. So rewards often gets a focus point because it's quite novel. But there's elements of maintaining a streak within the app. There's elements of moving up a leaderboard or participating in community challenges, of celebrating your wins with the community within Perks, as well as other kind of intrinsic and extrinsic motivators. What we find is that different people pull on different motivators. So whilst some people love the rewards and that's a focal point for them in terms of their daily engagement, we do find that others will earn a reward within Perks and never claim it. And so what we have really tried to do is provide that a smorgasbord as such of different motivational strategies. And what we're now starting to do as we refine the technology further is identifying how do we get better at understanding what motivates Scott and personalize the experience for him. So if it's clear that I am focused on rewards, and those rewards, I just see sort of the question pop up in the chat, they tend to be low value gift cards or charity donations. They're kind of the two big reward categories. And so it could be a gift card for a pharmacy or a grocery store or a convenience store, or a gift or a donation to a charity of their choice. If we find that Scott is particularly motivated by rewards, then every notification that we send Scott will be centered around that element of motivation.
Great. Well, thank you so much, Scott. And I want to just as we wrap up, just really thank all of our speakers. This was such a fantastic group of people. It was so nice to hear all these talks. And I think we heard a really broad spectrum of things, from how we're thinking about and measuring adherence in this current treatment era and this place we are with CF now, to how we encourage adherence and encourage people to stay engaged in their care as we figure out this new landscape together. So Carol and I, really just want to thank all of you and thank our audience for staying so engaged and providing such great prompts. I hope everyone has a really great rest of your conference, and looking forward to hopefully convening in person next year as well.